Hi everybody, welcome to our lunch and learn today, which is focusing on proactive care cohorts. We're expecting quite a few people in. If you've not used the town hall function before, which is what we're using today, it's a little different to a regular Teams. So we won't see you, and whilst we're recording this session, there won't be any of your kind of cameras or anything like that on the side. You'll just see the presentation that we've got going on today. You should also see that there is a Q&A function, which is the place where you can ask us any questions. And once we are finished with the live recording and the presentation piece, we will go to the Q&A, and that's where we'll be pulling all of those questions from. So please do, as things pop into your head and you've got questions as we go through, do make sure that you pop them into the Q&A so that when we get to the end, we can pick that up. So I am now going to introduce our speaker for the day, who I am sure will be well known to quite a few of you on the call. This is my colleague Graham Hyde, who has been working in business intelligence for the ICB for a while now and is our absolute go-to person for data. He tries to hide from us, but we always know where to find him and ask for data. He is going to give you a bit of a whistle-stop tour of proactive care and how we get to our cohorts, and also a bit of a live demonstration of the Curiosity tool itself. So I will hand over to Graham now. Thanks, Graham.
Thank you. Thanks for that lovely introduction. So I'm Graham Hyde. I hang out at the ICB in Leeds, and have done for quite a while. So I'm just going to, hopefully everyone can see my presentation. So I'm just going to take you through just a brief introduction to neighbourhood health and what we created that we call the Curiosity tool. So here we go. So we've calculated in business intelligence that 67p of every £1 spent on unplanned care in Leeds is spent on people in our proactive care cohort. That's about £457 million a year and about £10,500 per person per year. It's really important to know that this isn't a new programme. It's how we make proactive care our core business of general practice and system-wide working in a neighbourhood model. Basically, organising care around people, communities, and really with a prevention and proactive agenda. It's not about organisations and buildings. By the end of this session, I want everyone on this call to have a better understanding of what is neighbourhood health, why is it important, how the proactive care cohort was identified, what is the Leeds data model, what is the Curiosity tool, how do we find these people in real life, and how do we show progress and impact? How do we know we're making stuff better? So first up, neighbourhood health is about organising care around people, communities, and with a prevention agenda. Again, not around organisations or buildings. It's care that's integrated, joined up, proactive, and close to home. Neighbourhood health starts with people at home. Local teams use information to spot people who may need help earlier. Different people and services work together as one team, and the aim is to keep people healthier, more independent, and supported close to home. In simple terms, instead of waiting until people become very poorly, local teams work together to spot who may need help and support them earlier, nearer home. So this is Margaret. Margaret has diabetes. She has arthritis. She lives alone. She's been to A&E 3 times so far this year, and she's 82 years old. The old way would be we just wait until she becomes poorly again. The neighbourhood health way is we spot the problem earlier, we bring the right people together around Margaret, we visit her before a crisis happens, and we help her stay well at home. So why are we doing this? Most people and communities, I think it's fair to say, want to access health and care as close to home as possible, in a way that's most convenient for them and that gives them what they need when they need it. Duplication and lack of coordination between services in our current system create frustration for people, not just our patients, but us as professionals, health and care professionals as well. And the lack of capacity to focus on proactive care to reduce escalating needs drives cost. Leeds faces persistent health inequalities, rising complexity of care need as more people live with multiple long-term conditions and increasing demand. So we aim to create a proactive focus on people who are vulnerable to poor health outcomes because of frailty, multiple long-term conditions, or both. These are the people most likely to have an avoidable crisis or hospital admission. The big idea. What is that big idea? It's to help people stay healthy and happy where they live, helping people feel better closer to home, everyone working together around a cohort or a population of people. People get help near their house where they live. We help people before they get poorly. And hospitals are for people who are very sick, very poorly, and everyone gets help when they need it. So how is all this organised? The principles of a geographic neighbourhood health model is set out here, starting from people's homes at the bottom of the chart and their natural communities through to a wider population level and place at the top. It contrasts the current provision with future neighbourhood health elements, showing how home care, local GP and pharmacy, proactive care teams, specialist support, virtual wards, and shared records and financial flows could connect into a single pathway. It is clear that not every service can be delivered 15 times into neighbourhoods, so 3 multi-neighbourhoods are also in development, and there is some provision for doing things Leeds-wide. So these are our neighbourhood footprints. Everyone loves a map, no more so than me. And this is a map that shows neighbourhood footprint boundaries. Neighbourhood footprint boundaries are exactly the same as local care partnership boundaries and are built from primary care networks. The table to the right lists each neighbourhood footprint in alphabetical order with the number of registered patients for each one. Our 3 multi-neighbourhood footprints are shown here and have recently acquired names. We previously called them 1, 2, and 3, and now we've got a name for each of them. And these are built from our 15 neighbourhoods, which, as I said before, are in turn built from our 19 primary care networks. So hopefully you can see how things build up from people's houses, where people live, up to neighbourhood footprints, and then up to multi-neighbourhood footprints. So how do we know anything about the people in Leeds? We are incredibly lucky and fortunate in Leeds to have something called the Leeds data model. Imagine, if you would, Leeds as a place full of children, families, older people, vulnerable people, doctors, nurses, other clinicians, social workers, teachers, and volunteers. Everyone has a little piece of a very big jigsaw puzzle. The GP has a piece, the hospital has a piece, social care has another piece, community services have yet another piece. On their own, each piece only shows part of the picture. The Leeds data model is a giant table where all the puzzle pieces are carefully put together so people can see the bigger picture of what is happening in Leeds. And neighbourhood leaders are looking over the whole city. Different services send different information into the Leeds data model, including general practice, GP surgeries, hospitals, social care, community services, mental health services, ambulance services, 111, and also mental health services. The data is brought together safely with the intended outcomes to be better decisions, better planning, and better health outcomes for the people of Leeds. But before the data gets into the Leeds data model, names and other identifying details are replaced with special codes. This is called pseudonymization. It means analysts can study patterns without knowing who people are. So we can see that bigger picture. We can see where people are getting ill, which services are busiest, where do the inequalities exist, where do we need to add additional support or invest in a different way, or what is working well. So the simple message around the Leeds data model is it helps us understand the whole city, but not individual people. So if you remember right at the start of this presentation, I said that the proactive care cohort accounted for 67.2% of all spend on unplanned services in Leeds. That's about £457 million, or about £10,500 per person. We came up with this number. We didn't just think about it on the back of a beer mat. We'd done quite a lot of analysis looking at our population in Leeds. And we came up with that number after we started to look for people in our city who are high users of unplanned services. We obviously used the Leeds data model to do this. We wanted a way to also empower teams and leaders across the city to be curious about what the implications of high cost care means for their communities. And we decided that we would have an overall proactive care population of about 51, nearly 52,000 people. And they're made up of 3 separate populations. And as you can see there, population 1, moderate and severe frail people. Population 2, moderate and severe frail people plus multiple long-term conditions. And population 3 is just our people with multiple long-term conditions. So perhaps we could do something differently. We could empower our teams with the data from the Leeds data model. So we absolutely did that. So we created the curiosity tool. Hopefully the clue is in the title, which sits on top of the Leeds data model and helps neighbourhood teams explore the population to understand who might benefit from proactive care. It is a population health management and risk stratification tool which we use to identify people who are high risk, rising risk, or likely to benefit from some kind of coordinated support. Again, if the Leeds data model is that giant box of puzzle pieces that we've brought together, then the curiosity tool is that magnifying glass or even the pair of binoculars that helps you look at the puzzle and ask questions to be curious. For example, the neighbourhood team might ask, which people in my patch are living with frailty? Which neighbourhoods have the highest need? Which people use a lot of health and care services? And who might benefit from proactive support before they come unwell? The curiosity tool helps us answer those questions by looking at population groups, applying filters, and understanding the demographics and risk factors. It analyses service utilisation across primary care, community services and hospitals, and narrows down a really large population into much more manageable cohorts for action. And that's really important, that we create those manageable cohorts for people to act upon. So importantly, what it isn't, it's not a patient record system. We cannot identify people from the curiosity tool. It uses the Leeds data model and that data is pseudonymized. We do not know names, NHS numbers from the Curiosity tool or the Leeds data model. That's really important. Users can explore the patterns and populations rather than directly viewing individual records. But there is a requirement to be able to find people in real life, and re-identification is handled through a separate controlled process where appropriate. So what does this mean in reality? So as neighbourhood health develops, we want to be able to scale up the number of people we are working with in Leeds. Currently, the proactive care cohort is about 51,000 people, and there's an ask of the system led by primary care networks to actively, proactively manage 1.5% of the primary care network GP registered population by next year. So that's about 1,300 people. So how do we find these people in real life? I've been talking that we aren't able to see names and NHS numbers. So as I said before the data gets into the Leeds data model, names and identifying details are replaced with special codes. This is called pseudonymization. We're able to see that bigger picture, but to create the patient list for action, we need to be able to re-identify these people. And we can do that, and that involves a third party or desk row who can do this for us. They hold that key to unlocking the pseudonymization. Once we've done that, patient lists are then sent to general practice for further validation, coding, and action. It is critical that we understand and can demonstrate that we are making a difference to these patients and to the Leeds health and care system. We've got a number of metrics, as you can imagine, and we're starting to record and report on a wide selection of metrics. Number of people being proactively cared for, impact on unplanned activity, impact on general practice appointments, impact on ambulance conveyances. We've also got some information in there about patient experience, and actually we've also got staff experience being collected as well. And that's really important. We've got a really robust and quite a large evaluation program sitting around this piece of work. So everyone on this call is able to access the Curiosity tool. We will be sharing the slides later, and simply you have to request access yourself. You would do that by clicking that link that says AP Proactive Care Report, and you would follow the instructions. Full support, any advice, any hand-holding is available through that email address. So that's all I'm going to say about for in terms of some slides. And now I'm going to try and show a live demo. So I'm just going to try and stop sharing and share a different screen. So, okay. Abs, could you give me a thumbs up that you can see a screen that says Proactive Care Curiosity Tool? Yes, fabulous. So this is the Curiosity tool. So here we go. So all of the reports that the West Yorkshire Intelligence Function produces always has a front page. So that gives you notes, high-level information about what this report is. As you can see, bottom left, there's also a link to a help email address. So if there's ever any questions, do get in touch with us. So the report is designed in pages, in different sections, and we just click using our mouse. We just click through the pages and we can see various bits of information. So this is a good page to start with. So previously I talked about our 3 populations, and here they are, just as a reminder. And we're starting to see the numbers, the individual numbers in each population. So for example, in Leeds, in population 1, there are exactly 21,455 people that we have identified in population 1 living with moderate to severe frailty. And we've added in some hopefully interesting information about those people. So 23.5% live in IMD1. And for people that aren't aware, IMD1 is the 10% most deprived parts of the city. Average age, 71. 8% living with dementia. And then down here at towards the bottom, we can start to see the activity that those people are consuming. So we've highlighted here GP appointments. So we think that's quite high. So each of the people in that cohort, on average, is having 15.5. I don't know what half a GP appointment is, but that's the joy of averages. Let's say 16 GP appointments a year. Now, I'm not a clinical person. That might be excellent care, or it might not. It might give us an opportunity to do something slightly different with this cohort of people. As we go down the list on the left, we've got a master filter page, and that really does what it says on the tin. So there are a number of filters here. I think it's important to say now, you cannot break this tool. If you do, well done, and you get 5 gold stars, but you shouldn't be able to break this tool. You can search to your heart's content. So you might be within a PCN, you might be within a practice. So I'm just going to have a look within Central North Leeds at the Oldley Medical Centre. So we click it on, and hopefully you'll have seen that the data starts to change as we add and subtract filters. So within our particular practice, we've got 1,300 people within our proactive care cohort. And we can start to interrogate this data further. If we go into the demographics tab on the left-hand side, we start to see, okay, so this is a bit more interesting. So what's the gender breakdown? What's the age breakdown? What's the ethnic background breakdown? What's the deprivation breakdown? So this is obviously, if you know North Leeds, it's quite an interesting one, that we do have some deprivation, so that 10% most deprived parts of the city in this area. But we've also got quite a lot of people who are in the more affluent or less deprived parts of the city. We can look at the LTC tab. So LTC stands for long-term conditions. So let's click that. So again, that number there with 1,300 people at this particular practice in the proactive care cohort. So the tool is having a little think. Hopefully it won't take too long. And this page, when it appears, will show you within that cohort of 1,300 people, what are the long-term conditions that those people have against their primary care record that we've pulled through into the Leeds data model. So this is quite annoying that it's taken a little bit of time, and as if by magic, here it is. So we can see, interesting. So the largest number of people within this cohort, within that practice, have hypertension. I wonder if there's anything that we can do for that cohort of people in a slightly different way that might reduce the number of GP appointments for that population. And you can see the data is presented in a variety of ways. And we might want to think, well, what are we doing with our hypertensive population? We can also look at activity for our cohort. So we start to break that down into what sort of activity are our cohorts consuming. We can look at that activity over time, some nice line charts. And then as we get into a little bit more detail, so hopefully you've seen we've gone from a Leeds perspective, We've started to put our people into cohorts in our proactive care cohort. And then we've gone down to a practice. And then we've started to add some filters. We can really get into the detail when we come up with something called a theograph. Now, this is, I've pre-selected a patient just because this particular part of the report sometimes takes a little while to have a think. So I've pre-selected this patient ID. So that is a pseudonymized key. That is not an NHS number. And this particular person within the last year has had 106 GP appointments at Old Woodley Medical Centre. Now, again, I'm not a clinical person. That might be tip-top care, but it might give us an opportunity to do something differently. Again, we can start to click into here, and the patient ID that we've selected, we can start to see, crikey, we can start to see this person. We don't know who they are. We don't know what their name is. We don't really know what house they live in. But we can start to see all of the activity across our unplanned care that this person is having. And that's a lovely list. But sometimes we might want to see it as a picture. And we've got something here, which I particularly like. So this shows you, so all of the coloured boxes represent a part of the system of unplanned activity. And you can start to see, goodness me, that person is having a lot of GP appointments. Again, you can start to say, was there an A&E attendant that then tipped into community contacts, which might be a good thing. But hopefully that particular visualization will give you an idea of how we can see people's health and care utilization over time. Might give us a sense of escalating activity, escalating need, or people getting more poorly. So that's all I'm going to show you. We'll finish on a theograph because that's a good place to finish, I think. So I'm going to stop sharing my screen. And I'm now going to invite, I think, Kim or Abs just to have a look in the Q&A, and we can start to try and answer some of your questions.
So, Graham, if you've still got your slides open there, the first one that popped up, someone is really keen to get stuck into that process of looking at the Curiosity tool itself. Can we have the link in
Absolutely.
the Q&A? So you should be able to just ask a question around that one, I think, so that everyone's got sight of it.
So if I put that in the Q&A, let me have a look. So that should pop in at some point. So you just click that, follow the instructions. If you get stuck, give me a shout. You will need your mobile device. You need to set up what we call multi-factor authentication, but most of us within the NHS and other organisations as standard use MFA as that authentication. So hopefully it'll be familiar to you.
Brilliant, thanks, Graham. So we're going to start at the bottom of the list. Anybody else got any questions, do pop them in because we've got time probably for a few more. But the first question is, can you tell us what are the multiple long-term conditions that went into the tool, and is there a list somewhere?
I can definitely provide you a list. I haven't got that in my head, but I will definitely provide you a list, not a problem.
Thanks. So we can maybe, when we circulate the slides, we can pop that in with the slides as well. You might or might not be able to answer this one, Graham, because this speaks to the Leeds data model rather than just the Curiosity tool. But this is, who is the third party organisation? And it says, and will the public be made aware of the pseudonymisation in layman's terms? But I guess a broader question really of how have the public been involved to date in how we work with the Leeds data model?
Yeah, absolutely. So as an ICB or a CCG or a PCT, if you think about the commissioning world of things, it keeps on changing. we've had the Leeds data model for a long time. This is not a new product. It's well over 10 years old. So the information governance is well established. It is nothing new. And the pseudonymization is carried out by North East Commissioning Support Unit. Again, they provide all of our nationally commissioned data sets, so SUS, HES, loads of other bits and pieces, to us, and have done for many, many years. So the information governance is absolutely watertight. They are an NHS organisation. There's no private stuff going on here, I can absolutely assure you. And yeah, that's that.
Thanks, Graham. So the next question we've got, are the GP appointments just with general practitioners, or that range of general practice staff, nurses, pharmacists, physios, etc.?
Yeah, so it's all appointments within general practice, to give an overview of activity within general practice. So I think so that there is some additional detail around, because coming in for an annual review, that would be a count of one for a appointment in general practice, and that's good. That is good care. So we are able to then try and sort of a more of a one-off exercise to understand what types of appointments those are, but it really is that high level. What is the activity in general practice?
So tell me if I'm talking absolute nonsense here, Graham, but
That's
I
it.
think the way that we're using this is when we're using the curiosity tool, it gives us that bit of an idea of the
Mhm.
types of service and the sectors of health and care
Yeah,
that we're using. When we're looking at our evaluation and proactive care and how things are changing, we are able to look at total primary care usage, and then we can look at GP access, as specifically GPs, as a subset of that, can't we? So that we can
yeah,
start to understand how things are changing in that way.
yeah, absolutely.
One on data accuracy here, and it feels like this is a killer question. For the data to be
Yeah.
accurate, how are we ensuring the definitions of frailty, moderate and severe, and long-term conditions are being used consistently across Leeds?
Yeah, excellent question, and we do get that all the time. So how within the Leeds data model, how we define frailty, we use work that's built from the Electronic Frailty Index. So that's published work by Dr. Andy Clegg of Leeds University. So it's built up from those 36 deficits. Again, I can signpost people to various papers about the Electronic Frailty Index. So yeah, it's based on 36 deficits of things and conditions and items that are coded in primary care. And the more deficits that you acquire over your life course, we count them up. Each one's got a score, and we then create frailty levels. So that's how we do it in the Leeds data model. I think in the past we've had schemes in the city where people have validated certainly severe frailty, but we're looking here at moderate and severe frailty. In terms of ensuring things are consistent, we work very closely with the primary care data quality team. Again, they sit in the ICB. Work very closely with them to define how we identify long-term conditions, how we identify frailty. So we work very closely with them. Certainly from a Leeds data model perspective, we're pulling that information once, so it is consistent in that way. But we are also looking at when we deliver patient lists into general practice, there will always be some validation of those lists that has to take place, because in the interim period of people appearing in the Leeds data model, they may have passed away, they may have deregistered, the Leeds data model is not live data. There's about a 3-month lag from all of that data across general practice and national commissioning data sets arriving with us in the Leeds data model. So clinical validation is also very important.
I've got a couple of questions about the tool. I'm just going to take them out of order. So I'm going to take first Hannah's, which is Hannah's already straight on it. She's asked for permission to access the tool. How quickly is that likely to be granted?
Well, how it works is if you click that link and go through all the couple of steps and request access, cheeky little email will arrive in my inbox and I'll go, yep, okay, on you go. So if you were to do it now, before the end of 2 o'clock, you'll have access to the tool. It depends how quick you are and how quick I am to get those approvals sorted.
Brilliant, thank you. And then a little bit further down the line with the Curiosity tool. So someone's been in the Curiosity tool, working in primary care. They're looking to re-identify that patient list. Roughly how long is that taking, Graham?
Sometimes it's a little bit challenging. We're always trying to improve our processes, and we've put a new step in. So if people are interested, when we create a list of pseudonymized patients, in the past we had to seek approval for every single re-ID request from James Thomas. So he's a GP at York Street in Leeds, and he's also the West Yorkshire ICB Caldicot Guardian. Now we've decided that sending him multiple requests is not a good use of anybody's time. So in conjunction with the West Yorkshire ICB information governance team, we've said if the re-ID requests are of a similar nature for neighbourhood health, can we have that overarching agreement from James Thomas and IG to just get on with it? We have now got that overarching agreement, but we do need each general practice Caldicot Guardian to be aware of this work and to expressly give their permission for this re-ID work to happen. It can take a little while. Previously, when James was involved, it's a human in a process. We're all allowed to have annual leave, etc., etc. But we've got it a bit more slick now. So it's hopefully going to be about 5 working days, maybe a maximum of 10 working days to turn this around.
Thanks, Graham. And you mentioned about that kind of step in the process of the local Caldicot Guardians all having to sign up. For those primary care networks that have got a overarching proactive care team that's working across practices, that piece of work is either in train or has already been done via the primary care network manager working with those individual practices. So you might find that in your local area, actually, you're already ahead on that step and you can put your data requests through. So then second part of this, and I guess is reflecting a little bit this being a bit of a clunky process from the Leeds data model, is this something that TPP or the ICB could emulate in clinical reporting so that we've got access to a live list? So why are we using the Leeds data model and Curiosity tool rather than being able to construct it as a search in primary care?
I mean, that's a very good question. I suppose the answer is because this is the way that we decided that we wanted to do it. I suppose we wanted that that engagement between business intelligence, the ICB, and practices and PCNs, that we could build that relationship. It's really important that we capture and code the people that are being proactively cared for, because we, as an ICB, we have to make various submissions to NHS England, so we need to be able to count and capture that information, and we're using the Leeds data model to do that. We certainly could have developed clinical system searches. We certainly could have done that, but for this particular programme, we decided to use the Leeds data model and develop that curiosity tool on top.
So there's a question here that's about the curiosity tool and whether it's accessible to third sector organisations. I think you've just answered that question in terms of anybody can get access. I don't know if you're on to expand in terms of there is a difference between being able to access the curiosity tool and see that kind of data and who can ask then for people to be re-identified, isn't there?
Yeah, so anybody who works within the Leeds Health and Care Partnership can have access to the Curiosity tool. That includes all statutory organisations and third sector organisations. Most third sector organisations that we know about can already access it. If you aren't able to, it might be just that the Curiosity tool doesn't know who your organisation is, and we have to go through a process of adding a domain to an allow list on the tool on the server. Very simple process. What we can't allow is people with a gmail.com or a Hotmail or AOL account. We have to know that people are bona fide employed by organisations within the city working on neighbourhood health. You can't, my mum wouldn't be able to access this with her Gmail account, nor probably would she want to, but hopefully you take my point.
Thanks, Graham. And a quick supplementary question.
Yeah.
If a third sector organisation doesn't have a Microsoft 365 license, would they still be able to see the tool?
Yeah, it's not linked to Microsoft 365. So, for example, colleagues that work for, let's say, Forum Central, their domain is forumcentral.org.uk, I think. And that I know for a fact that colleagues in Forum Central, we've added their domain to the allow list and they can access the tool. In turn, I think you asked a question before about who can request re-ID'd data. That very much must come from primary care. So again, people working with PCNs, with a primary care manager, the data has to be sent back to primary care, and then it's imported into EMIS or System 1, their clinical patient systems for further work. So it must be via primary care because they own the data.
That's really clear. Thank you, Graham. So back to, again, how the Curiosity tool works and where it pulls data from. When we're looking at general practice data, if a practice mainly uses EMIS, but it might use System 1 to book in with some of its staff, would that all be pulled through as primary care data?
Yeah, we consume data from both System 1 and EMIS practices. Yeah, not a problem.
And a question from Shauna about social care and third sector data. So does the Curiosity tool show any referrals or any appointments from third sector or adult social care or any routes of referral in and out of these services, or is it just health data?
So we do have some adult social care data in there. We probably haven't quite got the depth of information that we have in terms of health data, but there is some activity data in the Leeds data model. There is also quite a big project to look at consuming activity that is happening in the third sector. Again, I think that's on our list of things to do. It's not complete by any stretch, but it is on our list of things to do. I suppose a slight blocker there is the use of NHS numbers. So when we're talking about our pseudonymization process and linking of data, that's done using an NHS number. So, for example, social care might not capture NHS number. The third sector might not capture NHS number. So that becomes a little bit of a stumbling block, but something that we can get over.
I think the other thing that would be interesting, Graham, and a little bit of a plug here on behalf of public health colleagues. Public Health have developed a health inequalities template that sits on primary care systems, and that is designed to pick up on some of the wider wellbeing issues that people are experiencing. So if somebody's got a housing issue, a range of other issues, then primary care can actually go into that health inequalities template that can log that those are issues, but it will then also direct through to the appropriate help as well. So it's a useful tool for primary care to use, but hopefully for us in the future, it's also another way of building up that broader picture of the supports that individuals need. And primary care practices are being incentivized to use that template this year to really get to know it and learn, and be able to start to fill things in so that we can develop that further. So that could be something that's really helpful for some of this, couldn't it?
Absolutely. I mean, not to underplay or overplay anything, it's just data. So if things are captured in System 1 and EMIS and we're able to flow that into the Leeds data model, then absolutely it will be there. Yeah, I'm aware of that template. It's some great stuff that the primary care data quality team in the ICB, who I just happen to look after as well, very proud of that work across the system that they've been involved with. So yeah, it's brilliant stuff. And yes, we can flow all of that good stuff.
Great. I think this last question might be as much for me to answer as it is for you, and it's another one that's not necessarily easy. So it's what communications are going to be shared with the public about how neighbourhood health is going to operate in Leeds going forward. There's so many different health strategies across Leeds currently. Will these be rationalised and more focused? I mean, I think you have some strong opinions, Graham, on
I
on
do.
communication and simplifying things. So you go first and I'll chip in.
Yeah. There is a lot going on in Leeds, and it's all brilliant stuff, but sometimes it does get a bit overwhelming, and it's like, well, what's that program, what does that mean? So hopefully in my style that you will have seen today, I'm trying to go really slowly and break it down into simple language. But comms is really important, and I think I've seen some stuff that has already come out that aims to simplify what is neighbourhood health, what does it mean for the system, for the public. I have an ambition that somebody in Leeds goes on Look North and tells everyone about neighbourhood health. But we do need to get that really simple and clear message. But yeah, I feel people's pain about how complicated it is. And if we think about how the principles of neighbourhood health, it's reducing complexity, delivering care around people. For me, reducing complexity is really important because at my age, I can't handle it anymore. And if it complicated for me and complicated for people who are putting questions in the chat, what hope in hell does a person aged 70 with moderate frailty, what chance have they got of navigating the system? We've got to keep it simple.
Maybe it's time to revive your Making Stuff Better podcast, Graham, as well.
Yeah, maybe.
Uh, so what I would add to Graham's is we do recognise that there is a challenge around
Yeah.
communications. There is a challenge on how we're communicating to our staff, and a lot of our workforce do actually also live in Leeds and do have families in Leeds. So actually part of the strategy is if we can communicate clearly to our staff, then we've got a whole load of people that can help us to get that message out to the public in ways where they know how to talk to their own friends and family and make things nice and clear. So even just being clear in our message to our staff would help. There is a lot going on. We have, as a program, been trying to rationalize and bring things together in ways that make sense. So we started off a couple of years ago that we had a whole load of different projects going on that we brought under the umbrella of Home First and proactive care, because essentially they're all trying to do the same things to support people in our communities. We're then trying to describe things in terms of, well, actually, the massive amount of transformation that we're doing in this system, a lot of it is about delivering on that neighbourhood health ambition. So how do we describe that in simpler terms and bring things together and make it seem less complicated? But also neighbourhood health is part of a much bigger ambition in Leeds around neighbourhoods in general and what we want for thriving neighbourhoods and our Leeds ambition that we've all signed up to. So there's definitely some thinking and some work in progress around not just what does this mean in terms of how we communicate to our staff, but also how do we then get that out to the public? We are also looking across the Pennines because this is one thing that we think maybe Manchester have got a bit of a head start onto us. So they've got a really clear way of sharing their vision. So we are thinking, what are the things that we could actually learn from there as well, and how do we do some of that? So yeah, watch this space. There will probably be a lunch and learn coming to you to test out with you neighbourhood health and how we communicate it all. So
I'm not
I'm
sure.
just seeing.
Can we learn anything from Lancashire? As a fierce Yorkshireman, I'm not sure we can do that.
One thing I said, Graham, one thing that I think they might slightly be ahead of us on. Didn't even say they were better than us, just slightly ahead on this
I
one
can't
thing.
see that's true.
Okay. So Councillor Jenkins is asking, does this link to the Leeds Observatory data? So there's pride in place areas that have resources to tackle deprivation. If we can start to link things across, then that really gives us a really great rich picture to work with. And then a supplementary comment on your theograph of 106 appointments sounds like a lot. Can it not be resolved? I guess proactive care, that's exactly the sorts of things we are trying to resolve.
Yeah. But as I said before, 106 appointments might be great care. If it's your mum or your gran, you might want that. But it does look a little high. So we would need to investigate, why is that happening? Is there something else that we could do with that particular patient? To answer your question about the Leeds Observatory, so I suppose we are data rich in Leeds, and we're very thankful for that. The Leeds Observatory is maintained by public health colleagues in Leeds City Council. So there is a slight difference between health-based data and council-based data, but we do absolutely talk to each other, and we can link data sets together, and we do absolutely do that.
Brilliant. So Ivan has really enjoyed seeing the visuals and the drill down, and understands that kind of benefits of looking wide and then funneling. But obviously re-ID is key, particularly for people who are working in GP practices, to be able to spot those actionable patients and proactively attend to them. So saying beyond the general cohort actions, will there be some logic tables shared on code clusters, etc., that bring patients into the groups?
We could do that. I mean, yeah, if we take each long-term condition, they will be made up of SNOMED codes. So that's getting right into the detail of how we've created those long-term conditions. We can publish that. I've got no problem in publishing that. So yeah, we could do that. Good question.
Just a comment from Chris saying, love it, Graham, simplify it and put the person first. Great feedback, Chris. And also, once we have got that narrative around neighbourhood health, you're absolutely my go-to person, because I know that you will always tell me if we're talking absolute jargon and it makes no sense. So thank you for that comment. So one around could be regular wound dressings if data just covering general practice, not staff member.
No, that could be. It could be. Again, that's so thanks for that, Ruth. Now you're getting into the curiousness of the data, which is exactly what I want you to do.
And I think that's it, isn't it? Like you said at the start, there might be really good reasons why somebody is having lots of appointments. This isn't about if somebody's got a whole ton of appointments, we need to change that, but it is around thinking, does this look right? And is this one we want to dig under a little bit more?
Yeah.
I'm going to give people about 30 seconds because I'm aware there's a little bit of a lag between us chatting and it actually reaching people. Slow wires or something like that, I guess. Yeah, we did see that it was linked to the 106 appointments, Ruth. It was really helpful. Thank you.
Thank you.
I think we might have managed to get through all of our questions with a few minutes to spare. So thanks everybody for joining us today.
Thank you.
It's been really great, actually. Some really brilliant questions in that Q&A for us to unpick, and exactly the sorts of things that we were wanting to see in terms of where you go with it. So next steps really, if the Curiosity tool is new to you, sign up, drill down, particularly if you are from primary care and sat in GP practices. Graham and his very small team are actually really happy to continue this conversation with you, sit and do demos, make sure that you are really familiar with that, because we do want it to be really interesting and helpful and useful to you in practice. Anything else from you, Graham?
Yeah, I can see that 11 people have already requested access to the Curiosity tool. So as soon as this has finished, I will go in and approve it. So thank you very much. And again, if you need any support, you cannot break it, give us a shout. Thank you very much.
And if you've enjoyed this webinar and found it useful and helpful, do tell all of your colleagues to make sure they get access to the recording so that they too can benefit from this information. But yeah, thank you all very much for joining us today, and we will finish now.